Good morning. I'd like to thank Professor Galanov and the organisers for inviting me to speak today on hypofractionated radiosurgery, the Radiobiological Foundation. In this talk, I'd like to cover the radiobiological rationale for fractionation, covering repair and re-oxygenation. I'd like to address some dogma and misunderstanding. I'd like to try to identify which tumours might benefit from fractionation and also look at the differences between benign and malignant targets. So we have the 5 R's of radiobiology. These are well known. The first one is repair. I'll be dealing with that later on. Redistribution is important if you're treating in a number of daily fractions, but you need typically at least 15 fractions to take advantage of redistribution effects. This is the redistribution of the cell cycle. Repopulation, well, that's only a problem if the course of the overall treatment is in days. In radiosurgery, typically we're treating in a single fraction, but if we are hyperfractionating, that's probably still okay because it's just typically around 5 days in length. Next, radiosensitivity. Well, we know that different tumours have different levels of radiosensitivity, and that's something else that we need to consider. But re-oxygenation, the 5th R of radiobiology, is very important, and it's often used as a justification for fractionation. But all of these 5 R's of radiobiology modify the clinical effect of the radiation. So let's look at repair. We know that tumour and normal tissue can repair some damage to their DNA between treatments or even during protracted treatments. And traditionally, tumours were considered to have less ability to repair themselves, and hence this therapeutic ratio exists. And I should mention that's for some tumours, not all. Another way of looking at this is in this chart by Bedford and Mitchell, where we have the dose on the x-axis going up to 18 Gray, and then the surviving fraction of cells on the y-axis. And you can see here that if you divide the dose up into 4 daily fractions of 4.5 Gray, that gives you the equivalent cell kill of a single dose of 10 Gray, which you see with the green dotted line. Now, sadly, in radiosurgery, there has been a tendency, I think, for some groups to take advantage of the 6th R of radiobiology, which is reimbursement, because there have been situations where hospitals are reimbursed per fraction, and so delivering the dose in 4 fractions or 5 fractions could lead to 4 or 5 times the technical fee of a single dose delivery. And I think this has really clouded the radiosurgery community's view of fractionation, and sometimes there is this automatic tendency to think that hyperfractionation is somehow better. But we need to look at the science. So why do we want to fractionate apart from a potential higher reimbursement fee? Well, the idea is we want to expand what we call our therapeutic ratio. We want somehow for our normal tissue to be less affected by the treatment than our tumour. And if our tumour has a higher alpha-beta ratio, that means it has a limited capacity to repair itself between individual daily fractions. And you can see in this classic chart exactly that, where a low alpha-beta ratio tumour, there's significant sparing, which takes place when you divide the treatment up into daily fractions, compared with the higher alpha beta ratio, the solid line, where you get a greater proportion of cell kill. This is one of the reasons that's used to justify fractionation. Here we can see two curves. We've got a red curve in the chart on the right hand side, which represents the equivalence of a single fraction dose to 2 Gray fraction doses for a high alpha beta ratio target versus the blue curve, which is for a low alpha beta ratio target. Now, clearly, if we look at, let's say, the radiosurgery dose equivalent of 20 Gray, and we can see this on the table on the left, for what we call late reacting tissues, or tissues with a low alpha beta ratio of 3, and they're typically thought to be normal tissues, you give an equivalent dose of 92 Gray in 2 Gray fractions. While if you look at early reacting tissues, which is the figures in red, you can see that you only give the equivalent of 50 Gray. And this really demonstrates, using this model, that fractionation gives you a much higher dose than the equivalent single fraction if you're treating targets with a high alpha beta ratio. So what alpha beta ratios mean? A low alpha beta ratio means that the tissue has a high ability to repair when the dose is divided into fractions. If a tissue has a high alpha beta ratio, it means that the tissue doesn't care if you divide the dose up. However, it's not the alpha beta ratio that matters. It's the alpha beta ratio of the target relative to the surrounding tissues. This is a very nice graph which comes from a paper by Alan Nahum. It's well worth reading this. What we're looking at here on the x-axis is the number of fractions, and on the y-axis is the tumor control probability for isotoxic doses. And you can see here that if you have a tumor with an alpha beta ratio of 10, then clearly as you increase the number of fractions, you increase the tumor control probability from around 15% up to around 70% when you deliver the dose in 35 fractions. If your target has an alpha beta ratio of 5, you're going from somewhere around 50% increasing to around 70%. If your alpha beta ratio is 3, you actually slightly decrease your tumor control probability as you increase the number of fractions. Now, this is assuming that the normal tissue has an alpha beta ratio of 3. And the reason why you're slightly decreasing the tumor control probability is due to one of the R's of radiobiology, which is repopulation. Now, if you have an alpha beta ratio of the target, which is 1.5, you actually end up decreasing the tumor control probability as you increase the number of fractions. Now, typically radiobiology is taught that tumors have an alpha beta ratio of 10. And this is pure and utter dogma. It's simply not true. It's a way of teaching how fractionation could work, but the concept that the tumors have an alpha beta ratio of 10 is something that was proposed decades ago, and the science clearly has shown that's not the case. So let's have a look at the alpha beta ratios that have been measured and published for typical tumors and targets that we treat in radiosurgery. If we look at the top of this table, melanoma, two estimates are 0.6 and 2.5. And Soren Benson, who published the 0.6 measurement of the alpha beta ratio for melanoma, I spoke to him a couple of years ago and he still stands by that figure. That means that melanoma can repair itself faster than normal tissue. And what that means is that if you hyperfractionate, you actually give the melanoma a chance of repairing itself faster than the normal tissue. So you're probably going to decrease your local control. Renal cell is around 2. Chordoma, 2.45. Vestibular schwannoma, there are various estimates, and calculating the alpha-beta ratio is extremely difficult to do. But you can see values of 1.5, 2.4, they're below what is considered the alpha-beta ratio for normal tissue, which is somewhere between 2 and 3. AVMs, two estimates are 2.2 and 3.5. Well, in a way, AVM is normal tissue. It's not neoplastic tissue. Non-small cell lung, I know a radiation oncologist recently that said that that was 10. But the last two papers estimating come up with figures of 3.9 and 2.8. Well, these are still very similar to normal tissue. Meningioma, 3.3 and 3.8, still very similar to normal tissue. And breast, as low as 2.9, 4 and 4.7. But you can see here, only glioblastoma has an alpha-beta ratio of around 10, which is what is often labelled for all tumours. So, and clearly we're not treating or rarely treat glioblastoma with single session radiosurgery. And that's probably why, because it doesn't work, because the alpha beta ratio is so high. In a way, our clinical results that we get with radiosurgery demonstrate that the targets we treat have low alpha beta ratios, because otherwise our treatments wouldn't work. So why do we sometimes fractionate? Well, I've already mentioned about the 6th R of radiobiology, reimbursement. I think some clinicians have a dogmatic adherence to an alpha beta ratio of 10 for tumours. That comes from their simplistic training. And some clinicians say that multiple fractions are considered to be kinder to normal tissue. Well, that's certainly true. If you fractionate, you will be kinder to normal tissue. But if your tumour has a similar alpha beta ratio to your normal tissue, it's going to be kinder to the tumour as well. So let's look at an example here. We've got a WHO grade 1 meningioma. It's abutting the optic apparatus. The target has a low alpha beta ratio. The surrounding tissues have a low alpha beta ratio. There's no difference between the target and the normal tissues. And so in theory, there should be no advantage in fractionating. So there's no radiobiological evidence whatsoever that fractionation is more suitable for large benign lesions or tumours close to organs at risk. For large vestibular schwannomas, the primary concern might actually be, it's not the dose to normal tissue, it's actually the effect of post-radiosurgical swelling. And if we look at the timeline for this, we have a treatment which, let's say, is given in a single session here, and then post-radiosurgical swelling tends to become a maximum at around 18 months, somewhere around that level. Now, if we want to do the same damage to the tumour but do it over a period of 5 sessions, that's really making very little difference to the overall timeline. If you're doing the same amount of damage but in 5 days instead of 1 day, is that really going to change the incidence of post-radiosurgical swelling? I've certainly not seen any evidence to suggest that it does. Let's look at another example now. We've got a glioblastoma. Our target has a high alpha beta ratio of around 10. The surrounding tissues have a low alpha beta ratio around 2 to 3. There's a difference between the target and the normal tissues, and then there is an advantage in fractionating. So let's ask this question. Every time we reduce the dose to a tumour because of its size, would we do better to fractionate? And according to the LQ model, the answer is yes, but only if the alpha beta ratio of our target is greater than 3 and the fractionated dose distribution is as good. And it used to be that if we treated, let's say, on a gamma knife with a single fraction, but if we wanted to perform hypofractionation, we had to do that on a gamma knife or a cyber knife. Sometimes there were concerns that the dose distribution wouldn't be the same, and that might affect the overall efficacy of the treatment. But nowadays, with the gamma knife icon, we can hypofractionate, give a single dose using the same device. Same with CyberKnife, same with Linac. So maybe that's not the case anymore. So now let's look at re-oxygenation. This is a fascinating subject. We must remember that re-oxygenation or hypoxia, and this is the fact that hypoxic tissues are more radio-resistant to the same dose of radiation compared with fully oxygenated tissues. Hypoxic cells need between 2.5 and 3 times more dose for the same cell kill. But these do occur in malignant tumours only. But this is used to justify conventional fractionation. Here's a really interesting table. It's actually published in a chapter on spine radiosurgery, but it beautifully illustrates the effect of hypoxia. So I've highlighted the row on this table which represents 20 gray, and we're looking at the surviving fraction of doses, surviving fraction of cells for that given dose. So for no hypoxia, we get 4.1 times 10 to the minus 9 cell survival. That's really enough to sterilize a typical tumor. If we then have 1% hypoxia, that surviving fraction goes down to 2.5 times 10 to the minus 5. 10% hypoxia, we're now 10 to the minus 4, and 100% hypoxia, we're now 10 to the minus 3. So it makes a huge difference just having a small amount of hypoxia. Now, one of the reasons for fractionation came from Jack Fowler's definitive work. He measured the control of transplanted mouse mammary tumours for the same level of skin damage for a variety of fractionation schemes, including single doses. Large single doses of radiation were notably inferior in achieving tumour control for a given level of skin reaction, and that provides justification for fractionation in radiation therapy. However, this inferiority could be entirely overcome if the resistance of the hypoxic cells in the tumours was eliminated by the pre-treatment of the mice with a large dose of hypoxic cell radiosensitizer. And this demonstrates that it's the elimination of hypoxic effects that generates the greatest enhancement in the therapeutic ratio that fractionation offers. In other words, the alpha-beta ratio really isn't as important as the effect of fractionation on hypoxic tumours. Hypoxia can be divided into two different types. Chronic hypoxia is caused by the tumours outgrowing their blood supply, and it's probably the most important. But you also have acute hypoxia, and that's caused by the tumour's poorly organised vascular network. And re-oxygenation occurs sporadically over a period of hours or minutes. So let's look at chronic hypoxia now. That requires tumour shrinkage. in order to resolve that chronic hypoxia. And staged SRS for metastases is a very good example of enhancing that therapeutic ratio, because at the second treatment, the tumour has reduced in volume, resolving some of that chronic hypoxia. Perhaps at the third stage, we get full re-oxygenation. That doesn't normally happen for daily hypofractionation. And then I mentioned we have acute or transient hypoxia. Here we've got a mouse model where a number of Eppendorfer probes have been placed in different capillaries in that tumour, and the hemoglobin oxygen saturation is measured over time. And you can see how rapidly this varies with time, just over a period of 40 minutes, huge changes to the oxygenation. So if you're treating a tumour instantaneously at around a period of 15 minutes, you can see that actually the hemoglobin saturation at that point is extremely low, and the tumour will be more radioresistant than it is at, let's say, 20 minutes or 25 minutes. And so one of the options of treating is staged radiosurgery for larger metastases. And this is the original Higuchi paper, which proposed 10 gray times 3 with 2 weeks between each fractionation. There was an 89% and 76% control rate at 6 months and 1 year. And the mean tumour volumes at the first, second and third treatments were 17.6, 14.3 and 10.6 cc, which represents a 39% reduction. Clearly we have problems managing these large metastases if we're not able to remove them surgically. These are the results from the RTOG 9005 study, which showed a clear correlation between dose and tumour diameter and patients that develop toxicity. So we can rearrange that data as a chart like this, where we can see that if we irradiate a tumour with 18 gray, if the tumour's less than 20 millimeters in diameter, we've got a less than 10% incidence of radionecrosis, while 2 to 3 centimeters in diameter, it's around 20%, but above 3 centimeters in diameter, it's around 50%, which clearly is unacceptable. So what do we do in that situation? Well, we can't lower the dose. This is a meta-analysis of a number of radiosurgery papers looking at 12-month local control. And we can see here that once we go down to around 18 gray, we're somewhere around the sort of 50-60% 12-month local control level. We'd really rather be above 20 gray to achieve durable local control. So one of the ways of doing that is proposed is hypofractionation. And in this paper by Shuriak, the group studied tumour control for 2,965 patients, a huge number. But actually, these patients were either with lung lesions or brain lesions. So actually, these were quite different patients. When they compared single fraction doses with hypofractionation doses, they found that there was actually no difference in the tumour control probability. However, when they looked at brain, they found a significant difference between single fractions, which were notably inferior to multiple fractions. However, they studied the dose at the isocenter and not the peripheral dose of the tumour. Now, if we treat a metastasis with the gamma knife, we tend to give 20 gray at, let's say, the 50% isodose, in which case the maximum dose would be 40 gray. If you deliver with a LINAC and you prescribe to the 90% isodose, then the maximum dose will be 22.2 gray. The peripheral doses of those two treatments are exactly the same, but according to this study, they were treated very differently indeed. And so it tends to be that the single fraction data here tends to be treated with a lower isodose, and it's penalized for having a higher internal dose, which is something that we don't really take into account when we're treating a patient. We're really interested in the peripheral dose. And the team actually admitted here that if peripheral doses were used, the evidence became too weak to differentiate between single and multiple fraction SRT. And this is clearly for malignant targets only, so wouldn't count for benign lesions. This is the very first stage radiosurgery patient treated in the UK, a patient with a perfect performance status but a huge brainstem in the Met. We actually delivered two stage treatment for this. So 10 Gray at the first stage, the volume was 7.2 cc's. 2 weeks later, when we delivered the second stage, we had a 33% reduction in dose. And we can see the slides here showing that we got a durable response at 17 months follow-up. And it was at that point, actually, the patient returned because they had developed new metastases. Here's another interesting case. This is a three-stage treatment for a metastasis in the pituitary stalk and gland. So you can see at the first stage here, we delivered 10 Gray to 1.14 cc's. At the second stage, we had a 42% reduction in the volume. By the third stage, it was a 67% reduction. And this was a fantastic case because it allowed the tumour to shrink away from the optic apparatus. So on the first stage, the tumour was abutting the optics. We had to give subtotal coverage of the target with 10 Gray. By the second stage, we had about 0.5 millimeters distance from the optics, so we were able to get full coverage with 10 Gray. And then at the third stage, we had about 1.5 millimeters from the optics and were able to give full coverage again. And the optic apparatus received around 7 Gray times 3. So stage radiosurgery involves giving the same BED but splitting the dose to exploit tumour shrinkage to gain geometrical advantages, which you saw in the pituitary case I just showed you. But also a smaller tumour means a steeper dose fall off and lower biological effective dose to the surrounding tissues. We also get additional re-oxygenation effects due to the resolution of chronic hypoxia, and these treatments are ideal for the gamma knife icon. It's important when we're comparing single doses with hypofractionation. We have our classic sigmoid curves. Let's say we're comparing a 13 Gray dose with, let's say, 21 Gray in 3 fractions. Now, what we would see here if we studied 2 different patient groups like this is that there would be no difference in local control because at that BED, we're at the top edge of the sigmoid curve for tumour control, but we would see a significant difference in the complications. But that's clearly not due to the fact that we're hyperfractionating, it's just due to the fact that we're treating a slightly different BED. So it's absolutely essential that when we compare single doses and hyperfractionation, that we have a good understanding of the BED. So what's best? If I was to fly from London to Moscow, I could do that in a single flight. But if I was to hyperfractionate my journey, it might look like this. So I'm still getting to the same place, I'm still getting to where I want to go to, but it's just taking longer. And I think that's what hyperfractionation is for a lot of cases. It's not going to do any harm unless your tumour has an extremely low alpha-beta ratio, for instance, melanoma. But I just wonder how much good it actually does. What we're clearly trying to do is improve the therapeutic ratio. And we can do that by increasing our conformity, our dose gradient, and applying fractionation where appropriate. So to summarise, the dogma that tumours have an alpha-beta ratio of 10 harms our understanding of radiobiology. Conventional radiobiology predicts that hypofractionation has no value in the treatment of benign disease because there's no repair differential and there's no hypoxia. Clinical results don't appear to contradict this view. Fractionation may help in the control of hypoxic tumours, but the treatment course needs to be long. And adaptive staging of METs may confer a dosimetric benefit by reducing doses to normal tissues. Its prolonged treatment may allow re-oxygenation. I'd like to thank you very much for your attention.